Welcome everyone to another virtual shadowing session at Hearts for Health. We hope your year is wrapping up pretty strong. It's already December. This year has been a pretty crazy year. It's gone by pretty quick, but it's felt like quite the year. But we're glad you could join us today. This is going to be one of our last sessions for the fall semester, and we're going to continue with more shadowing sessions into the spring. Today, we're joined by Callie. She's a PA practicing internal medicine in Canada. The last time we had a shadowing session, we had a PA practicing in Scotland, in the UK. So we're seeing how the profession looks like abroad, which is really interesting. A few reminders, though, especially if you're new to our virtual shadowing program, towards the end of each of these sessions, let's say the last 15, 20 minutes or so, we have a Q&A. And if you have any questions for Callie or any other future speakers that we have on our program, feel free to type them in the chat under either to the side of the live stream or under the live stream. You'll see that chat, and you can type them in at any point in time. We'll read them out at the very end. Also, one more reminder, in case, again, you happen to be new, there's two ways that you can go about hearing more about our shadowing sessions as well as our other volunteering programs. While we do have virtual shadowing going on, we also have 4 other volunteering programs. Some are in person, some are virtual, and you can hear about all of them either through our Instagram page or through our listserv, our email listserv. Our Instagram page is where we post pretty much everything to do with virtual shadowing in our programs, and the listserv is exactly the same. The only difference is that the email listserv is a weekly email sent out on Thursday mornings, and that's something that you can subscribe to either through our website. We have a subscription form at the very bottom of each of our pages, or you can email us at community@hearts4health.org. We'll include the email address in the video description at the end of today's session. Those are all my reminders. If you have any questions, feel free to email us. We're happy to answer them. But to not take too much time, feel free to take it away, Callie.
Thank you very much. Good evening, everyone, and thanks to Hearts for Health for inviting me to participate. My name is Callie Braun. I'm a Canadian certified physician assistant working in internal medicine in Winnipeg, Manitoba, Canada. And so a little bit about me. I have my Bachelor's of Science that I did at the University of Manitoba and graduated in 2011. It was a 5-year degree. It was an honors as well as a co-op. So my major was in microbiology. My minor was in management. And I did a double work term in HIV and human genetics, and as well as a work term in the clinical microbiology lab. Following that, I did my Master's of Science in medical microbiology, looking at the human genetics of tuberculosis disease in 2 Canadian cohorts. And then that was in 2013, also at the University of Manitoba. Following that, I worked for 4 years for undergraduate medical education. And also in that time, I had 3 kids. So they're now 6, 8, and 10 years old. And then I went into the PA program. So that was a 2-year program, I think technically 25 months, the Master's of Physician Assistant Studies, also at the University of Manitoba. Following graduation, as you can imagine, it was August of 2020. We were just getting our feet wet in a pandemic that was going to last for many years. So my first job was actually an outpatient COVID assessment. So in a time when PPE was short and people couldn't really get in to see their family doctors, or family doctors' offices were closed, these COVID assessment centers came about in Winnipeg, where you could go to get tested. You could go with COVID positive or influenza-like illness with worsening symptoms that you were concerned about from a respiratory standpoint, or if you were COVID positive and you had other issues that you would normally go see your family doctor for, but they weren't wanting to see you because you were COVID positive and not allowed in their office. So that's where I started my career. I moved to inpatient family medicine following that. So that was someone's mat leave that I was covering for a year. And so that's within a community hospital in Winnipeg. And that's kind of all of their care, from screening admissions to doing their care while they're in the hospital, as well as discharges. Following that, I worked in the virtual COVID outpatient program, or VCOP. So this is a unique program that was created in Manitoba for patients that were sick with COVID, requiring supplemental oxygen, but that was their only reason that they didn't need to be in the hospital. So not so sick that they needed to be admitted, other than that they were on oxygen. So we sent these patients home with like oxygen tanks, and we met with them over Teams every day and worked to wean them off of their oxygen from home. And they had a pulse ox and they had a thermometer, and we would kind of monitor them every day. And if they got really sick, they'd have to come back to hospital, but otherwise we would wean them off their oxygen and kind of meet with them instead of every day, every other day, once a week, that kind of thing. So some long haul patients out there. And then finally in May of 2022, I got my current position. So I'm a permanent position, internal medicine at Health Sciences Center, which is the largest teaching hospital in Manitoba. I also, what else do I do? I teach for the Department of Family Medicine, so PA learners and med students as well. And once in a while, I'll teach some basic life support through Heart and Stroke Foundation. So a little bit about PA training programs in Canada. There's currently, as of this moment that I'm talking, 3 training programs for the entire country. So one is the University of Manitoba. It's the only master's level program. And then in Ontario, they have the University of Toronto and McMaster University, which are running bachelor's level programs. But lots coming on the horizon. So starting in January of 2024, Dalhousie is going to be starting up a master's program, and the universities of Calgary, Saskatchewan, Ottawa, they've all made announcements of programs coming in the next 1 to 2 years. So on internal medicine, our hospital has 3 clinical teaching units, or CTUs, as well as an overflow service. And each of those kind of have a different footprint in the hospital. And so I work on what's called D medicine. And I work with about 2 to 4 different physicians each week. So on my contract, I have about 32 or 35 different docs, but I don't regularly see all those people. And at one time, I'd be working with 2 to 4 of them. And generally on the ward, we have 31 to 32 beds, depending on the day. And I'll follow about 10 to 12 of those patients. Okay, for my best try, I tried to embed this video and I couldn't. So I'm going to toggle to a different screen and let me know if you can hear the sound, and we'll watch this quick video that HSC made for me. My name is Callie, and I'm a physician assistant at Health Sciences Center working in internal medicine. I've been working at Health Sciences Center since May of 2022. I work on the same unit in HSC every day. There's about 30 patients on that unit, and about 10 of them are under my care. I review the labs, check in with nurses, and I go around on my patients every day and provide them the care that they need, whether that's consulting other services or working up in a new acute issue. I think it's really beneficial to the staff there that I'm always on site. So some of my attendings, they have residents to train, they have clinics to run, but I'm just there taking care of patients for the full day. The most rewarding thing is also the benefit of having a PA on internal medicine is the continuity of care. So every 2 weeks, the attending physicians change, and I'm always there. So the patient has me through their whole stay. So anything that may not have worked, in prior days or weeks of their care, I'm familiar with all of that and where they've come right from the beginning of their admission. You work with this amazing group of intelligent physicians and you become part of the medical staff, and they value your presence on the unit and the care that you take for the patients. And so really just being part of the team here. It's a very fulfilling career. You can go anywhere you want, and over time, if you decide you want to switch to a different specialty or from medicine to surgery or vice versa, we have the ability and the flexibility to go wherever we want. I mean, every day is actually a great day. I love what I do. Yeah, like there are no bad days. Like for real, I really like coming to work. Okay, awesome. I'm glad that worked. November 27th in Canada is National PA Day, and I had done some promo stuff with the communications department, and they surprised me with that video. So a day in the life. I work Monday to Friday from 8 to 4. And for the most part, what happens for my day is I come in, I review the charts to see if anything happened overnight. So if there's nursing notes, if the patient was crashing and got sick and someone had to get called to come in and look at them, or any consultants that you may have been asking for advice on to see what's been written in the chart. I'll review labs, then I'll go see the patients, and then I'll write my notes and follow up on any tasks that might need to be done. But I'm constantly interrupted. So I'm on the unit all the time, and the nurses and I have a good working relationship. So if a patient has a question that they can't answer, a family member shows up and wants an update right now, family member phones the unit and wants an update, a critical lab result comes in, there's a question about a med, I'm always there, and they'll just come bug me in the middle of what I'm doing, which is fine. That's the benefit of being there, is that we can answer questions on the spot right when they come up. So let's talk about some patients. So some of these are all real people that I see. Some of these patients are actually still admitted to the hospital, and I've bolded some of them that we will turn into cases to talk about. So patient number 1 is a 38-year-old female with fungal endocarditis. So this means she had a bloodstream infection caused by a fungal pathogen, and it has grown on her heart valves. Patient number 2 is a 68-year-old male with spinal osteomyelitis. So this is an infection in the bones of his spine. He's a gentleman that would come to the hospital, get some antibiotics, feel well enough, and then leave against medical advice over and over again. And finally, he got sick enough that he needed to stay due to pain in his back and decreased mobility. And they actually finally found out that he was growing tuberculosis in his spine, which is why he was not responding well to antibiotics from all of his prior visits. Patient number 3 is an 88-year-old female with an intracranial hemorrhage or a bleed in her brain. Patient number 4 is a 42-year-old male with a skin and soft tissue infection on his left hand. Patient number 5 is a 52-year-old male post-liver transplant. So he was a guy who came to us from a rural hospital with acute liver failure. He was flown to Toronto for a transplant. He had many, many complications and spent 2 months in Toronto before coming back to us, and spent 3 more months with us. Many surgical complications, many infectious complications, unable to eat, and ultimately got a peg tube or a surgical tube through his stomach to be able to feed him. And we were able just recently to transfer him back to a rural hospital closer to home for him to try and build up some strength. Patient number 6 is an 89-year-old female with stroke and sepsis. So she had a bloodstream infection, which was treated, but had very poor oral intake. And so when that happens, you can get electrolyte abnormalities that can make you more tired and drowsy, and can lead to even coma and death. And so we kind of revived her with IV fluids, and actually finally she rallied and started eating more and was paneled to a personal care home, and family was very thankful that she kind of was brought back to life, because it was touch and go for a while. Patient number 7 is a 60-year-old female with an AKI, or acute kidney injury. Patient number 8 is a 46-year-old male with a diabetic foot ulcer. Patient number 9 is a 62-year-old female with metastatic cancer and COVID. So patients that have cancer that are in the hospital sometimes are surprised to hear that we won't provide any chemotherapy to them while they're in the hospital, even if it was previously scheduled to happen on a certain date. And so chemotherapy, as you can imagine, is very hard on your body. And so for someone who is sick to start off with, or having functional decline at home, that gets put on pause while we try and make them better. Ultimately, this patient's oncologist said that we couldn't offer her any more chemo ever. And so family were just focusing on quality of life over quantity of life. And patient number 10 was a 42-year-old female with C-spine demyelination. So this means that the nerves in your spine are starting to lose their coating, if you may, and not doing the job that they normally would. So her symptoms were dizziness and nausea and blood pressure changes, and they were finding that there was lesions in her brain and in her spine that they attributed to an autoimmune infection. So we'll dive into a couple of these cases a little bit more. So the 38-year-old female with fungal endocarditis. So this is a patient who very unfortunately has Crohn's disease and had her colon removed because of extensive disease. Because of that, she needs ongoing IV fluids to maintain her hydration at home, and has a chronic line always to give herself those IV fluids, which has become infected. So she came into hospital and her blood was cultured and it was growing candida. It's a fungal a fungal agent. And when we see that, we look at the heart. And so this picture on the right-hand side is an echocardiogram, which is an ultrasound of the heart. And I don't know if you can see my cursor on here. So this is the heart valve across here, and this is actually a vegetation that's kind of flopping around on your heart valve. And so sometimes we can treat patients with bacterial endocarditis with IV antibiotics alone. But on the left-hand side, you'll see a table here from the New England Journal of Medicine, which shows some of the indications for when we need to do surgery on a heart valve. So one is heart failure, meaning that the valve has a vegetation on it so big or in a place that it doesn't allow it to function properly. You'll see here as well, a fungal pathogen alone will make you a candidate for cardiac surgery, as well as multi-drug resistance, blood cultures that are continually positive, even though you're giving them the right antibiotics, or a vegetation that's a certain size. So this patient actually got transferred off to the other kind of major hospital in Winnipeg. That's our cardiac excellence center for cardiac surgery. But while she was with us, just as may happen all the time, is that patients come into hospital with one issue and they get complications. So she had a new complaint of abdominal pain, and on exam, her belly was quite distended, her bowel sounds were hyperactive, minimal ostomy output, and she was actually vomiting fecal material. So when you think about a bowel obstruction, you think about no bowel sounds, but sometimes they can be hyperactive. And if nothing can go down, then things start coming up. And so patients with bowel obstructions are often nauseous, vomiting, and then sometimes in severe cases, they are vomiting fecal material. And so this is from Google, but this is a X-ray of a belly that's very similar to the one that she had. And here you can see dilated loops of small bowel. And these lines here are called air fluid levels, and they're indicative of a small bowel obstruction. And so sometimes we manage these cases with surgery, but in her case, she's had a number of abdominal surgeries and she has adhesions, which would make going in for surgery quite difficult. And so we manage conservatively. So we put an NG tube through the nose on suction to decompress the air out of the stomach and any of that fecal material. And we give anti-nausea medication, anti-pain medication, and we actually don't let the patient eat. As you could imagine, we're trying not to put anything in if there's a blockage. And so she recovered well from that. Patient number 2 is an 88-year-old female with an intracranial hemorrhage. So on the left-hand side here, I've just listed some modifiable and non-modifiable risk factors for stroke. And in the picture on the other side, you'll see kind of the two classifications of stroke. So the majority, about 87% of strokes, are the one that you see on the far right here. So it's called an ischemic stroke. So there's a clot and it prevents blood flow to the brain, and then the brain cells start to die. And on the other side, you have what's called a hemorrhagic stroke or an intracranial hemorrhage. And this is where there's a bleed in the brain. And so stroke centers will have what's called a stroke protocol. This one I've just taken off the internet. It's not from my center, but it just describes, you'll hear time is brain. So as you could imagine, if there was a clot or a bleed in your brain, and as it becomes larger and larger, affecting a bigger area of the brain, you're going to lose more function. And so in our hospital, if you're at Health Sciences Center in Winnipeg, you'll hear pages overhead that are called stroke 25s. And so EMS will be coming from the community with a patient they think is having a stroke, and they'll call ahead to the hospital and tell them, you know, we're going to be there in 7 minutes, and they'll mobilize the stroke team. So in minutes 0 to 10, a stroke neurologist gets mobilized, and they're basically waiting at the doors when the patient comes through to assess them to see, is this really concerning for a stroke, or is this a stroke mimic? And within the first 10 to 30 minutes, that patient is in the CT scanner. And following that, they look at the scan and they decide within the next, 30 to 60 minutes, there's some things called TPA, which is essentially a clot buster, if appropriate, or consult for a thrombectomy, which is a neurosurgery procedure where they literally go and retrieve the clot, again, if appropriate. And so this is an example of a CT of a brain like our patient here. And so she had a left-sided stroke. So when you look at a CT scan, this might look like it's on the right side, but you have to imagine that you're looking at the patient from their feet up. And so you can see up through their head that way. So this is a left-sided intracranial hemorrhage. And the deficits are then on the opposite side. So she was flaccid on her right side. She had a right-sided facial droop. Her right arm and right leg didn't work, and she was aphasic. So she could understand, to the best of our knowledge, what we were saying to her, but she could not produce speech to talk back to us. And so in these patients, there's a number of things that happen. Physiotherapy is activated, occupational therapy, the speech language pathologist, because usually when someone has a stroke, we don't let them eat any food because we don't know if the muscles for swallowing are still working or not. In this lady, she originally had an NG tube through her nose into her stomach, and that's how we were feeding her. And with ongoing assessments with speech language pathology, she was able to start eating, and we took the NG tube out. Shortly after that time, however, she decided that she was going to refuse all intake. And in a family meeting and meetings with the patient, she could communicate with head nods, yes, no. She communicated with us that this is not how she wanted to live. So her past medical history before having this devastating stroke was just acid reflux, and she was living independently in the community. So being bedbound, unable to move, unable to speak, she communicated to us that her goals were to be kept comfortable, and that she decided that not eating was what she wanted to do. And ultimately, she passed away comfortably with family by her side. We have a 42-year-old male with a left hand infection. So I don't know how comfortable people on this would be with a gnarly looking wound. So I chose a nice picture instead. This was a guy who came in with a left hand infection. And essentially, if you can see kind of the circle that I'm drawing over these tendons, his hand was eroded in this pattern. So probably about 3 centimeters by 6 centimeters, and all of his tendons on the top of his hand were all exposed. And so when you see these extensive infections or infections in weird places, maybe like a liver abscess, we test people for sexually transmitted and bloodborne infections. And so in this patient, he actually was newly diagnosed with HIV. And why this is important, so why we think about HIV or an immunocompromised host in these abnormal infections or that we might see, is it affects your CD4 count. So when we talk about HIV positive patients, we often talk about what their CD4 count is. So if a normal count is 1,000, and this virus is gonna, it's the human immunodeficiency virus, it attacks your own immune system, and the CD4 count will slowly drop over time. And this picture here is, without treatment. And so we don't know where someone is along this curve when we get a new positive. And so then we send off to find out what the CD4 count is. And this is important because as your CD4 count drops, you become more and more immunocompromised. And so someone with a normal immune system can go about their life and cross paths with different pathogens that their body fights off that they never will get sick from. On the other hand, if you are immunocompromised, we often call these opportunistic infections. And on the left-hand side of this table, you'll see a CD4 count, and then you'll see some infections, and it's important to measure CD4 count. So this gentleman was in the 300s, and so he doesn't need any prophylaxis, but patients that are falling kind of in this brown, yellow, or red area may take prophylactic drugs every day to try and prevent an infection. So pneumocystis jirovecii can cause a pneumonia or a lung infection, and patients go on an antibiotic every day to try and prevent that at a lower dose than a treatment dose. Less than 100, we think of a candidal infection. So this is like a fungal infection, and those people are on antifungal medications every day. And then the really low, less than 50, there's a virus called cytomegalovirus, and patients will also be on prophylaxis for those. So this gentleman doesn't need any prophylaxis medication, and he was started on HIV treatment in hospital. So hopefully a CD4 count improves a little bit. A 60-year-old female with an acute kidney injury. So here's a little picture of our kidneys, and then our ureters go into our bladder, and we drain our urine through our urethra. And so an acute kidney injury is defined as a creatinine that's a 1.5 times increase, or urine output that's less than 0.5 mLs per kg per hour. I'm in Canada, so we measure our creatinine in micromoles per liter, and a normal would be somewhere between 50 and 95. If you're in the US, you measure in micrograms per deciliter, and so your number is a bit different, 0.6 to 1.1. These numbers can fluctuate based on age and gender. And so when someone has a kidney injury, this lady's creatinine was in the 400s, and we usually try and divide this into three ways. So one is called, a renal problem. So there's something actually wrong with your kidneys. One is called post-renal. So that's anything after the kidney. So this is all the way down here. And then the last is pre-renal. And so this often talks about the status, the fluid status in your whole body, and is not actually really related to a kidney problem. So a pre-renal AKI is commonly dehydration. And so this can be determined based on history and physical exam of the patient. If they say, I was really sick with a stomach bug and I've been throwing up and having diarrhea and I'm not interested in eating anything. I haven't had water, I haven't had soup, I've had nothing. They're totally dry on exam and the story fits. And these often respond to fluid resuscitation. So pretty quickly, if you give them IV fluids, their creatinine will become normal. In the post-renal, this is often an obstruction. So this could be a large kidney stone. This could be a large prostate. This could be a tumor that is either within the bladder or extrinsically compressing something, not allowing urine to drain. And we diagnose this with an ultrasound. And if we find that, that's also a pretty easy one. We can throw a Foley catheter in for the most part while we work on resolving whatever the obstruction was that's causing that. Renal is a bit trickier. So here's just a diagram of the kidney. And when we talk about a renal caused AKI, we break it down into a couple categories. So you'll see that on the next slide. So this is a kidney here. And kind of you see all these little lines and they've blown this up. It's called a nephron. So there's like 1 million nephrons in your kidney, and they have what's called a glomerulus. They have this noodle looking thing called the tubule. They have the vasculature, and then everything else is just called the interstitium of the kidney. And so when we look at a renal AKI, like I mentioned, tubular, vascular, glomerular, and interstitial. And so this gets like way more complicated than I can even show you on this screen. But there's a number of different things based on drugs that the patients have had, their history, if they've been acutely ill. And then there's also a bunch of blood work that we can send off. And so this patient came back positive with a glomerular cause. So it's called PR3 vasculitis. And vasculitis is essentially an autoimmune condition where your body is creating antibodies that are attacking your own blood vessels. And we treat this because it's an autoimmune condition. We immunosuppress patients and then, watch their creatinine. So like I had said, in the pre-renal and the post-renal, sometimes those things we can fix them. The creatinine gets better right away. In the renal causes, sometimes these people go on to have chronic kidney disease with a chronically elevated creatinine. And the last case here is a 46-year-old male with a diabetic foot ulcer. So his past medical history includes type 2 diabetes. He previously has had a right below knee amputation because of a diabetic foot infection. He wears a prosthetic on that leg, and he comes in with a left foot infection from CIVP. So this is the community IV program. And this is where someone goes every day to a clinic to get their IV antibiotics. That saves them from having to be in hospital if they're otherwise well. And so how do we determine how we treat someone? So when we grow a culture, whether it's a blood culture, urine culture, a wound swab, we get things in stages. So the first thing the lab tells us is whether or not the bacteria that's growing is gram-positive, which looks purple on a gram stain, or gram-negative, which looks pink on a gram stain. Gram-positive might be something like Staphylococcus, Streptococcus. Gram-negative, something like Klebsiella or E. coli. And we can make guesses on our choices for antibiotics based on that. But then we can, in our next step, the lab grows up what they've seen on the gram stain, and they tell us the name of the bug. So here we have Escherichia coli or E. coli. And the third piece is this antimicrobial spectrum. So they'll grow that bug with a bunch of different antibiotics, and then they'll give us a susceptibility profile. So S for susceptible, R for resistant, and that can tell us what we can treat this patient's specific infection with. However, we do get cases where we never culture anything. It may have been difficult to grow. They may have had a poor sample. They may have started a patient on antibiotics before they took the sample. And so we have to make a best guess. And so here's a table. Across the top, you'll see some different types of bacteria. So MRSA is methicillin-resistant Staphylococcus aureus, and SSA is methicillin-sensitive Staphylococcus aureus. So MRSA is the superbug. And then we have some gram-negatives across the top in red there as well that are somewhat common. And so in this patient, we actually didn't know what the bug was that was causing his infection. So when he left his prior hospitalization on CIVP, they started him on ceftriaxone and vancomycin, which is a very common combination. And so if I've just kind of outlined the coverage here. So ceftriaxone has two separate boxes here. So it's covering lots of gram positives, but not our superbug, and a good amount of gram negatives as well. They throw on vancomycin. You'll see there's some overlap here in the MSSA and streptococci, but specifically to cover MRSA. And so people with diabetes can often have poor wound healing. And so this can be for a couple reasons. If your blood sugar is high, that's a nice place for a bacteria to live because it can eat that sugar. Patients also with advanced diabetes can get complications in their vasculature and can have decreased sensation in their feet. So sometimes they might not realize the problem is as bad as it is because they're not having as much pain that someone else might have. So this patient comes in, he has this ulcer. We look at it on clinical exam. Sometimes we'll do a probe to bone test where we'll stick like the end of a Q-tip in there to see if we can hit bone. And then we do an X-ray to look for osteomyelitis. So this gentleman on X-ray has the head of his fourth metatarsal has osteomyelitis. And so what that means is that you're going to need to be on an even longer course of antibiotics because now we need to treat the bone. And usually these people will have, we'll say like 6 to 8 weeks of antibiotics and then repeat imaging to see if there's improvement. This guy says his foot keeps hurting. It keeps hurting, keeps hurting. We're expecting it to get better. We changed up his antibiotics from the ceftriaxone and vanco that he was on out in community, and things aren't getting better. So we do a repeat scan, and he's progressed to the point where he has an abscess right adjacent to the fourth metatarsal. And we actually had to call orthopedics to come drain it. And in the process of draining it, they also consented him to have his fourth and fifth toes amputated. After that, pain way better. So we call this source control, right? If you imagine you have like an abscess in your foot and you're treating with antibiotics that you're getting through your IV, it needs to travel through all your blood vessels and try and target kind of a walled off collection of bacteria in your toe. It's pretty tricky. So when you go in and you drain it, you get rid of that ball of bacteria and things get better for the patient. And so in this case, we sent him home on ertapenem and vancomycin. We still don't have a great idea of exactly what's causing his infection, but this worked well in the hospital. And so if you compare what we're covering that we weren't covering before, you'll see the ceftriaxone box is here. It's exactly the same as ertapenem, but it's on this side. So we're covering anaerobes. So anaerobic bacteria is bacteria that grows without oxygen. And if you could imagine kind of a deep tunneled down infection inside your foot, that's a place that doesn't have oxygen. And so that's the piece that we felt was missing in his coverage before, was the anaerobic coverage. And so he went home with 2 less toes on a new regimen and was feeling really well. And that's the end of my cases.
Well, first of all, I don't think I've maybe learned more in one shadowing session. That was a lot to take in, but I mean, very easy to follow along. I learned quite a lot, and I'm sure quite a lot of students listening in feel the same way. To jump into questions, I wanted to kind of hit it off with something just kind of big picture in terms of your profession and where you practice. If someone is, let's say, trained in Canada, how easy is it for them to practice in the US and vice versa?
Yeah, so Canadian PAs are not allowed to practice in the States. So the US has the NCCPA certification, and their criteria to write their certification exam is that you graduated from an American PA school. I think one day that will change, but currently Canadian PAs hard stop, can't go to the States. However, in Canada, we do accept American trained PAs. They are welcome.
Love going one side, only one way, right? Um, but that's very informative to know, though. And just personally, did you ever consider working outside of Canada? I know that Canadians can't work out in the US, but like I said, recently we had a PA working in the UK, and we've had a couple other international speakers. Did you ever consider working outside of
You know, I
Canada?
didn't, and probably because I had a young family and quite settled down here that I wanted to stay here. Within Canada, Manitoba has kind of the best, I will say this, maybe other PAs in Canada will disagree with me, but Manitoba has the best kind of situation set up for PAs currently. We have the only master's level program. We have a regulated title with the College of Physicians and Surgeons of Manitoba. We are unionized. We are decently compensated. Um, and I think that there are some tough times in Ontario and they're fighting for regulation right now. And so without a regulated title, any person can call themselves a physician assistant in Ontario. And without a bargaining unit, people are trying to get paid fairly in a world of kind of the wild, wild west.
Yeah, yeah. I hear that in Canada, the profession is being it still is reaching up to that point of like being standardized or fully regulated.
Yeah,
Are
we're
there
not
any,
even in all of the provinces. Like new announcements this year, it looks like we will be in all of the provinces. Some have announced regulation, but yet to have PAs working. So we're almost coast to coast. But you're right, there's probably about 1,000 of us in Canada compared to well more than 100,000 in the US.
yeah, yeah, quite the difference there. I wanted to ask, are there any other differences you've noticed between Canadian PAs and US counterparts?
Yeah, so I don't know that I'm super knowledgeable to speak on that, but some big things that you'll notice are PAs in the States can bill for their services. So I believe they bill at a rate that is a percentage of what a physician would bill. And here we're like salaried employees, so we don't bill for our services. Um, so it's not like I must see a certain number of patients in order to get paid or anything like that.
I see. And also, I mean, you touched on it, personally to yourself, but generally, what sort of settings are do PAs usually work in Canada? In the US, it's usually primary care offices, and they can switch specialties, just like you mentioned. They have that lateral mobility, just like you mentioned, for Canadians. But in terms of setting, like inpatient, outpatient, rural,
Yeah,
urban,
we're basically working everywhere. So PAs are working in primary care. They're working in hospitals and specialties and subspecialties. A good portion of PAs, like probably 35% are working in surgery. So like I personally know PAs here working in plastic surgery, oncology, hepatobiliary surgery, ENT, vascular, like cardiac surgery, a lot of surgery PAs. We also have a large employer of PAs here is on Ongomuwazin Health Services. So Manitoba is a very large province with lots of First Nation communities up north. And so we have rural and remote fly-in PAs that are going up to the nursing stations to practice in those communities and be the sole provider, actually.
interesting. Also, to talk about specialty, internal medicine is yours. What led you to that? And given the timeline, I think it's 2 years, right, in Canada that you actually are in PA school.
Yeah.
When did you find yourself actually making that decision to go for internal?
Yeah. So our program, the first year is didactic in the classroom, and the second year is on rotation. And so, I tell people that when I went on rotation, the first week of rotation, anywhere I went, I hated it. I came home, I was like, this not for me. And on internal medicine, that lasted for 2 weeks. 2 weeks of my internal medicine rotation, I was like, I'm not smart enough to do this. I don't like this. And then by the end, I was like, this is really where I want to work. When you start off, people having like multi-morbid conditions, and where treating one is going to counteract the way that you treat the other, and just having to balance 12 different issues all at once. I totally love it now. I knew early on in my schooling that I wanted to work in the hospital. I find that way more exhilarating than doing outpatient care. And people that work at outpatient say they would never work in internal medicine. So I totally get that it's just whatever kind of strikes you. But internal med is really cool. And working at the teaching hospital, like the largest kind of hospital in Manitoba, we have so many services on site. And so we get some really sick patients, we get some zebras, presentations that are super rare, but that because of the type of hospital and services that we have available, that we get to see.
And like we touched on earlier, you can move on to another specialty, or even go back. Have you
Yeah.
any colleagues who've done that, and what's been their experience with adjusting to a new specialty?
Yeah, for sure. People will say things like it takes, 2 years to feel comfortable where you are. So I know someone who started his career in pediatric neurosurgery. Then he went to internal medicine. Then he went to bone marrow transplant, and now he's working as an ICU PA.
Wow, quite the story. Another thing is, and for you, it seems to be teaching, but a lot of people try to differentiate themselves outside of clinical practice. We've heard speakers who've been in not much of the clinic setting as much as they are just maybe in a public health office, or like you are with teaching, or even entrepreneurship. We've seen that a couple times. How do you feel like you can get your foot in the door with differentiating yourself? Is it really just as simple as going up to the institution, wherever that is, and moving forward from there, or do you need to have actual networking, actual connections?
Do you mean like after you're already in practice, or do you mean as someone who's looking to go into?
After you're already in practice, once you're actually credentialed and ready to help out with patients, doing things outside of just the normal day-to-day patient care.
Yeah. So, I mean, I think for myself, many of the things that I'm involved in were people that asked me to get involved, and it was less about having to go hunt those things down. So, I think before you go into a program, you might see that people are involved in many different things, right? Like if you look at some of the physicians that I work with, like they wear 10 different hats. And you think, how did you get into all of that? But once you're working, many opportunities arise, and you kind of start off very eager, saying like, I'm going to say yes to every opportunity. And then you see that there's a fair number of opportunities, and you can actually start to pick and choose what you feel passionate about and where you want to spend your extra time and get involved in. And so I work strictly inpatient, but there's definitely some inpatient hospital specialties that have clinics that are run, and the PAs work in the clinic, for example, like one afternoon a week or two afternoon a week.
Did you personally consider maybe moving on from internal medicine to another specialty?
I think I'm going to stay here for a long time. So, like imposter syndrome doesn't go away. So even if other people say that you are good at your job and you have lots of autonomy and you're seeing your patients and you don't see your attendings all day and they're not even involved in the care of your patients, essentially, like they're very much in the background unless you need them, you still feel like sometimes you don't know what you're doing. And so internal medicine is so broad that I feel like it'll take a long time before I feel like I've maxed out what I can do there, and look to move on. But the possibility always exists, right? There's nothing that makes us have to stay where we are. And some people I know have been straight out of graduation working in the same job for 10, 12 years, and other people have continued to bounce around.
And having gone through the whole process leading up to actually now practicing, why do you feel like it is that imposter syndrome is so prevalent in the healthcare space? Like I don't really hear it as much, in other work environments and other industries. What are your thoughts on that?
Yeah, I don't know. I don't know if it's because it's a high stakes game, right? We're taking care of people. And if it was easy, then it would be algorithms and computers could take our jobs, right? But it's you learn what you learn in a textbook, and then medicine is anything else. They say anything can be anything, and honestly, as you go through and you learn, the best learning comes from the cases that you see in front of you. And so it takes a long time to build up a wealth of knowledge. It feels amazing to see something like a clinical presentation and be like, I got this, I know what's going on. But certainly doubts cross your mind, because like it doesn't happen like it is in the textbook for sure.
Yeah, it is definitely high stakes. It makes sense in that facet. Another question we had is, you mentioned that you trained kind of in the midst of the pandemic, and because of that, I'm sure your training had a little bit of a different focus to it. But outside of that obvious and apparent change, was there anything else that you noticed was different about your training than it was for people who practiced, or sorry, who trained before COVID?
I don't think so. So when the pandemic hit, everything shut down in March, and I was in my clinical rotation. So the students in first year, they went on to Zoom and um, they stopped having class in person. We were on rotations and everything paused because no one really knew what happens with COVID. It was a new virus. There wasn't enough PPE. No one really knew. And so we paused for about a week, and then our program put us back on site. And other learners, like the med students, I think were off for 3 months, but we went back. And it is a very different time then than it is now. You got one mask and a paper bag, and you needed to save that mask all day because it's the only mask you're getting, and you had to sign out your mask. And there was lineups outside the hospital because they were taking staff's temperature when they came in. It was wild. But in the end, like some of our rotations changed a little bit. So people that hadn't done primary care, where you would go to a family doctor's office, they couldn't do those rotations because family doctors weren't seeing patients, right? Care was virtual for the most part, and very few people were seeing people in person. So I had already done my family medicine rotation, but some of my colleagues, they had to go and do inpatient family medicine instead of traditional primary care. So, I mean, our program is small. We have 15 per year. And so I think we had the flexibility to kind of pivot and figure out how to finish this, and know that, getting more practitioners out of the program functioning is a benefit in the pandemic. And so now that things have settled out, I would say everything is back to normal. So there was a little bit of bumpiness, but the whole world was stumbling at the time. So it kind of just felt like we would get through it, and it's not bad looking back on it.
If everyone's going through it, eventually something has to happen to make it change, right? Makes sense. One other thing that I think would be interesting to kind of hear your thoughts on is the emphasis that they place, at least admissions wise, going into PA school. In the US, it's about metrics, but at the same time, I think there's equally as much of a focus on extracurriculars and just how you convey yourself. How would you say that stacks up to the emphasis admissions for Canada?
Yeah, so at the University of Manitoba, our program doesn't require any clinical background or clinical hours, which I think is different from many of the programs in the States and even the programs in Ontario. I think that used to be a criteria, but then they felt like it actually doesn't change the type of practitioner that they're making in the end. And so the PA program here has a holistic approach. So it's not just your grades that they look at. Obviously you have to submit your transcripts and stuff like that, but you write a statement of intent. And so you basically try and, pump yourself up and write this letter to the program telling them why you want to be a PA, why you want to go to the Manitoba program, why you'd be a good fit for them, and to highlight your successes kind of in life that have led you up to this moment. And then if you get an interview, it's a day-long process. So you don't just get what's called an MMI, a mini multiple interview. You also have to write an essay timed in front of them. And then you also have a panel interview where it's you and 3 or 4 other people sitting across from you asking you more personal questions. So if anyone on this call has ever done an MMI, those are things like, do you give the organ transplant to Mother Teresa or the 20-year-old drug addict, right? It's like you have to choose a side and make your points. But this panel interview is them actually asking you questions about yourself. And so I think that is helpful to try and highlight who you are, and not just that your grades are a number on a transcript, or that you've practiced for how to answer your questions on your MMI, and to try and really pick holistic, good applicants to the program. I would say, like, compared to other people, I probably didn't have the strongest GPA. Like in Canada, we're out of a 4.5, and I was under 4 for sure.
Yeah, well, I think it was popularized, the whole MMI process in Canada, and it kind of spread on to the US. I know.
Oh, really?
Yeah. I actually just had an MMI earlier this week. Funny that you mentioned it. Just yesterday, actually. My first one. So
Okay.
what a coincidence. But yeah, it definitely I guess tests your skills as you would probably have to exercise them in a patient encounter. So it makes sense to be testing it that way. Another thing I wanted to ask is, we've heard from past speakers who've practiced in the US and who are still, or who train in the US, that they've gone through residencies after PA school. Is that the case also in Canada?
No, so there are a couple. Well, okay, I actually don't know what's happening in other provinces. So in Manitoba, I can only think of one program that has an additional training program. So the ICU, when they hire PAs, they hire them into a 6-month training program, which has sim labs, didactic lectures, and kind of a formalized training program, just because it's a specialized area. Other than that, I don't think anything else does. And for the most part, this is changing a little bit. For the most part, all of the PAs in Manitoba are unionized, and so we have a set pay scale, and we all make the same amount of money. And so having a residency program, one would expect that going back to school for additional training would come with additional pay. And in Manitoba, that wouldn't be the case, because we all follow the same pay scale. Not to say that someone wouldn't want to do the additional learning to, for their own knowledge and their own practice. But if it comes down to like an extra year of training, you think that you'd have higher salary. It doesn't happen. And probably because we're so small, the development and the upkeep of a training program would be difficult with such small numbers.
Mm-hmm. Earlier, you mentioned that as of now, there's no particular clinical experience requirement set in place as there used to be. If someone was to go out and get clinical experience in Canada, though, what types of clinical experience would that often be? Like, are we talking shadowing or actual volunteering?
So when I think back to my class, just like in terms of this spread of people that you get, we had people who were someone who was an assistant in an optometrist's office, someone who volunteered at like a psychiatric facility. We had an actual practicing respiratory therapist. We had an ICU nurse. We had an occupational therapist. I have my master's degree in research. We had someone who didn't have a science degree, a Bachelor of Arts, like really from a wide range of backgrounds, with both formal clinical experience and then other maybe less formal, like volunteer shadowing type experience.
And then, since we're almost towards the end of today's session, there may be 2 more questions that we can maybe fit in. The first being, I believe nurse practitioners are I'm not sure if they're just as common as PAs. Do you know if that's the case?
I don't know what the numbers are. So we do have NPs, I would say, for the most part, and this could be wrong because I'm not 100% sure, but I think for the most part, they're in primary care. We do have some that are like specialists in our hospital. So we have an HIV nurse practitioner, a GI nurse practitioner working with IBD patients, a hematology nurse practitioner that I see regularly at work. But they're also practicing in primary care and they can hold their own patient panels.
So if someone was to, let's say, compare those two professions, what are the main differences between them in terms of their scope of practice?
Yeah, so you often will hear nurses are trained in the nursing model and PAs are trained in the medical model. So that's true. PAs need to get a PA degree. They don't need prior clinical experience. And we have a whole year, so like 2,000 hours of training. And then the nurse practitioner program, they're nurses before they become NPs and they have to work as a nurse, I think, for 2 years before they go to NP school. Um, I believe NP school is also 2 years, but less hours of clinical practice compared to PA school. And then I know that PAs are working in primary care. I don't know how many PAs are working in like the specialist work in the hospital, but I think in the States and maybe some other provinces like Quebec, PAs are working hospital type, like hospitalist type roles. But I don't see that in Manitoba.
Interesting. Yeah, the whole part about training is very similar to the US, but a couple other things definitely draw differences from what we've seen in the US with past speakers. Very interesting to hear. And I think that really brings us to the end of our session. I really do appreciate your time, Callie. I just have a couple reminders before we close out for our shadowers, for those listening in. So at the moment, we just published our quiz link in the video description. If y'all would like to have, if y'all would like to be credited for the time that you've taken to attend this shadowing session, that's the way that we go about certification. It's a Google form. Once you click onto it, you'll see 10 questions. And if you get 6 or more out of those correct, then you'll receive a certificate. That certificate will be sent to an email address or the email address that you list on the quiz. And if you have any questions or if you happen to have any trouble receiving that certificate, please feel free to email us. The email is also in that video description. Another way you can go about finding our quiz is through our website under the virtual shadowing page. And one more thing I want to get to is if you want to get in contact with Callie, her Instagram handle is on the slideshow here. We really do appreciate you inviting any students to ask questions. A lot of times we get students asking about how to contact speakers, so it's very helpful. Thank you so much, though, for your time. We really appreciate it, Callie.
Yeah, thank you for having me.
All right. Well, I hope everyone enjoys the rest of their week. And the next shadowing session we'll have, just to let y'all know, is going to be in January. So unless we have a shadowing session scheduled in December, we will let y'all know. But until then, January 18th is going to be the next shadowing date that we have. And that one is going to be with a dentist. So for our pre-dental students, we do have speakers for you coming up in the spring. But that's all for tonight. I hope all of y'all have a great rest of your night and you enjoy the